Hi everyone, thank you very much for inviting me to give this talk. I'm going to talk about planning patient-specific constructs in adult spinal deformity. I'm Zeeshan Sardar. I'm a spinal scoliosis surgeon at the Oak Spine Hospital with Columbia University in New York. Here are my disclosures which are relevant since some of the products we will discuss are Medtronic. So step number one for planning a patient-specific surgery is really to decide what part of the spine you're going to do the surgery on. And I'm going to show a couple of case examples to drive that point. So here is a 67-year-old female with low back pain and left leg pain, mainly in the L5 distribution. As you can see, the patient has lumbar scoliosis and also has a thoracolumbar kyphosis. But her pain is really coming from the lumbosacral region with the radiculopathy as well as lower back pain. So part of patient-specific planning is really, as we all do, to try to understand what is the patient coming in for, what are their symptoms, what is bothering them, and how we can address those symptoms specifically. So then this patient, her pain was primarily coming from the lumbosacral junction. She was auto-fused at L3, L4, so just above where I put the screws. And she did not want to have a big surgery. So we decided to just address the lumbosacral region from L4 to pelvis. She underwent this fusion with the 2-level TLIF and has been very happy with the outcome so far. On the other hand, we have another patient, a 55-year-old with right leg pain, also related to the lumbosacral region, but she has a bit more generalized low back pain. She has mid back pain as well, and she's also unhappy with her posture as well as the scoliosis itself. And so this patient, her symptoms are more general, related to the upper thoracolumbar deformity as well. And so in her, we decided to do a fusion from T2 to the pelvis and addressed her radiculopathy with the TLIFs at the base. So that's step number one for me. Step number one is to determine what kind of surgery the patient needs. Step two is then once you've decided what kind of surgery the patient needs, then the next step is to understand what kind of alignment they should have after the surgery. And so in the older days, it used to be essentially in trying to get an idea of the sagittal malalignment by using PI-LL mismatch as well as the SVA. And as you all know, we have a lot of newer concepts now to understand alignment and what the alignment should be after the surgery. We have the SRS Schwab classification, or the concept, which talks about PI-LL mismatch, SVA of less than 4 centimeters, and the pelvic tilt of less than 20, and that is still quite commonly used. The second one, I guess in the last decade, has been the age-adjusted alignment targets, which is based on the age of patients. So for older patients, we can accept more sagittal malalignment as opposed to younger patients. Dr. Rusuli from Europe has talked about the Rusuli types or shapes of the spine, and that is based on the sacral slope as well as the pelvic incidence of the patient. And so that is a newer concept which mainly talks about the shape of the spine as opposed to specific numbers itself. We have the GAP score, which looks at different alignment parameters such as the lordosis in relation to the pelvic incidence, the distribution of the lordosis, whether it's more at the distal part of the lumbar spine or the upper part of the lumbar spine, as well as global alignment. And so that has been also shown to correlate with mechanical complications. And more recently, we have started assessing patient's alignment or the target using target goals from asymptomatic volunteers, and that is the means study group, which I'm referring to here. And so we have looked at a large population of asymptomatic volunteers to see what their alignment in the sagittal and coronal plane is. and then we can use the normal alignment to try to get normative targets for patients who are coming in for deformity surgery. But as you can see, this is becoming quite complex. We have a lot of parameters, a lot of different classification systems, a lot of goals to look at for each specific patient, and that can become complex and confusing. And so overall, though, the goal really is for us to have a patient who is standing upright, whose center of gravity of the skull is over the hips, that which is over the knees, which is over the ankles. So that's really the ultimate goal. But how do we get to this goal? Well, the next step then is trying to understand how do you execute that plan or execute or the goal that you have set for a patient based on the alignment parameters that you choose. And so, again, a few years ago, what I was doing was doing all this manually during the surgery myself. We had an idea of what the target should be. We bend the rod to that shape that we think the patient should have, and then you get x-rays intraop to see if you achieved the goal or not. But you didn't really have a good idea of how close you were to that goal. There was a lot of bending of the rod involved prior to placing the rod, and then also in situ bending. So lots of challenges in the past. Now we have the ability to plan these constructs prior to surgery, and also to have rods pre-bent and planned according to the specific patient's alignment targets that we are hoping to achieve. So this is a patient that I treated with an iatrogenic flat back. She was referred to be from somewhere else. She had undergone a fusion somewhere else, but you can see she does not have enough lordosis. She's quite flat. She can't stand up properly. So in her case, we planned the appropriate alignment using the custom rods software, and then once we're happy with the planning of the alignment, then we can request for those rods to be made in that shape, as you can see here. And so we had the rods made in the appropriate shape to get the right alignment. And then intra-op, I performed a pedicle subtraction osteotomy, and you can see here the correction that we achieved with those pre-bent custom patient-specific rods. And the nice thing about these rods is you can use one rod to get the correction, and you can also then use another rod to just place on the spine to check, to verify that you actually got the correction that you wanted to get. So this is a great example of that. Here's her standing x-ray. You can see that she's not bending her knees as she used to prior to surgery, and she's standing quite upright. Here's another patient I had with a flat back. She had Haddington rods placed many decades ago, and she had severe sagittal malalignment and coronal malalignment. And same thing for her. We planned the correction using the software for the custom rods. We plan to do a pedicle subtraction osteotomy and an interbody fusion at L5S1. And this is the alignment that we were hoping to achieve for this patient. And this is the post-op. We were able to achieve our goal correction very nicely with using these custom rods, as well as planning all this prior to surgery. So here's our before and after the surgery, using a patient-specific planning as well as patient-specific rods. And you can see her standing completely upright before and after the surgery. Here's a patient, 61-year-old, again, who had surgery somewhere else, was fused in a flat position, could not stand up. And so again, we planned for the alignment that this patient should have, and then we requested the rods to be made in that shape. And here's this patient before and after the surgery. And like I said, the nice thing about having custom or patient-specific rods made for the alignment is that you can literally just put the rod on the spine once the correction is done to confirm that you got the alignment that you're hoping to get. All right, so just like we use it for revision surgeries and flat backs and to get the lordosis, I also use patient-specific implants and rods in patients who have coronal problems or scoliosis. So here's a patient, 68-year-old female with scoliosis. You can see the planning here in the sagittal plane. In the coronal plane, the goal is to have the rod straight. So the planning is mostly done in the sagittal plane, and you can see how we are planning pretty much every part of the surgery. We're planning where we're doing the osteotomies, we're planning the T-lifts and how much lordosis you're going to get at every single level, and we're also planning the overall alignment and global alignment. So those are all the numbers you're seeing on the side here to really get to the alignment that we want to achieve. And so that's where having these patient-specific rods and implants becomes so important, because you can plan every single part of the alignment, and then you can execute that because the rod is made to that shape. So here's this patient before surgery and after surgery. Again, we got really good alignment. Patient's very happy with this. The key here is that alignment or patient-specific constructs don't just stop at the rods. There's more planning, more execution to patient-specific constructs. So, once you have the rod planned, you have the alignment planned. For me, another very important part of patient-specific planning is planning the screws. And here's an example of a 54-year-old female, again with prior Harrington rod, fusion mass, difficult anatomy. Prior surgery was done as a teenager, and so the patient-specific planning in this case also involves planning screws, difficult screws. As you can see, there are small pedicles, there's a big fusion mass, there's a rod in the way. So part of the planning is planning appropriate screws that would allow us to get the correction in this patient. And so I do use one of the robots quite frequently, and you can see we have planned out each screw that I'm going to use. The screws are planned so that they are the biggest diameter and longest screws that we can get in these patients, so specific to the patients, and also the positioning of the screws is very specific. So you can see it's important for me to know exactly how deep each screw is going to be placed, because my rod is going to be made based on that exact position. So here's a plan for the screw placement, and here's then the final execution of it post-op. Really good purchase of these screws, even in patients who have osteoporosis, because you are not doing multiple passes. You are doing a very precise one pass. We're putting in a big diameter long screw. So even in osteoporotic patients, you can get good purchase using very specific planning. Here's a patient who is a 34-year-old female who had a prior anterior or lateral surgery. Some of the segments were fused. She has a pseudoarthrosis. The rod is disconnected. And now she has a lot of lower back pain and some upper back pain. And so again, this is her 3D image, and we planned, again, screws specific to her, so that we can place these screws around her prior screws and instrumentation. And you can see some of these screws in the middle are short screws because we couldn't get them long enough because of these screws that are at the front. So again, it's a very specific plan made for this patient. Every screw has been predetermined and measured that we will use. The other nice thing you can do with this planning is I can move the starting points of the screws so that everything lines up well. And so I played with the starting point of all the screws to make everything line up straight. And here you can see all the screws line up straight. You get a straight rod in the coronal plane, and then you get the correction in the sagittal plane. And you can see some of these smaller pedicle screws in the middle because we couldn't get long ones due to the screws anteriorly. So now the next step is, is to bring all of this together, is to merge the planning of your alignment, planning of the rod, and planning of the screws into one, so that you really become even more specific to the patient. And so here's an example of a 30-year-old female with a high-grade spondylolisthesis, where I planned the screws for this patient, and then we also planned the alignment. And the initial rod plan we got was this red-shaped rod. but based on my screw plan, I knew that that shape was not correct. So we then were able to integrate the plan of the screws as well as the plan of the rod to get the final shape of the rod, which is curved in almost this S shape. And so this gives us the correction that we were looking for this patient with the high-grade spondylolisthesis. And here is her full standing x-ray. Another example of merging of all these technologies together. This is a patient with prior Haddington rods T4 to L2, now has a lot of lower back pain, radiculopathy. And you can see she's bending her hips and knees and ankles to try to be able to stand up. Here's a 3D model of her spine. She's fused. Some of the landmarks are not quite visible because of the prior fusion. And so we planned, number one, the screws to be placed safely, but I was able to plan the screws such that we don't have to even take the prior rods out. So you can plan the screws around the prior Haddington rods to avoid taking them out. And the other thing you'll notice is that because this patient still has a pretty significant scoliosis and rotation, the rods might end up being two different shapes based on the placement of the screws. And for someone like her who has a remnant scoliosis in the thoracic spine, I wasn't planning on completely derotating and making the lumbar spine straight, because otherwise she'll be out of alignment. So the goal was to decrease the lumbar scoliosis to match the thoracic scoliosis. So we planned on the alignment, and we planned two different rod shapes for the left and the right, so that we could get partial correction of her scoliosis, but get full correction of the sagittal alignment at the same time, and not derotate the spine too much. And so you can see two separate rod shapes that were planned for this patient. And this is her pre-op to post-op. So even post-op, you see those two different rod shapes. You see the scoliosis in the lumbar spine is partially corrected to match the thoracic scoliosis. And here's her imaging pre-op and post-op. Again, overall looks really well aligned in both planes. She's not bending her hips or knees or ankles anymore. And we have a very nice patient-specific construct now. And here you can see the overlap of the planning versus the execution. So it almost 99% is matching what we had planned with the screws and the rods and the T-lifts, everything. So the next step going on to the patient-specific constructs is patient-specific interbody implants. Now, I don't use this a lot because most of the time I don't think we need it, but there are definitely situations where I think this could be relevant and very useful. And so again, this is done with the use of planning software. This is a patient who has a prior fusion and now needs an extension of this fusion down to the sacrum and pelvis. So we have, again, our pre-op targets, our post-op targets are here, and an intrabody implant at L5S1 is then designed to give me the maximum correction from the L5S1 interbody space in the sagittal plane. But in some cases, if you have a lot of coronal malalignment, you can also get this implant manufactured so that you get a lot of correction in the coronal plane as well. And here are the details of this plan. You can see this, the way the implant is made, it's really meant to conform to the shape of the end plates nicely, so that it gives you that maximum correction that you're hoping for, but also gives you a much better contact surface to allow or to aid in hopefully getting a higher fusion rate. And here we also did this planning using a T-lift in case I did not want to do a lift, in case I wanted to do a T-lift for this patient. So similar planning can be done. And here is an example of a regular implant versus a custom implant. You can see for patients who have coronal malalignment, you may have surfaces that are not really being covered properly with an off-the-shelf normal implant, whereas with a custom implant, they really conform the shape of the implant to get the correction and to the end plates to get the maximum surface area coverage for fusion and for stability. And then just moving on to your patient-specific constructs for patients who have really complex spinal deformities. Another thing that we use quite often is printed 3D models. So here's a 3D printed model that I print for these patients, and I take this model to the operating room to help in planning as well as execution of the plan and for placement of screws, because sometimes technology such as robotics does not work so well with such complex deformities. And so here is this patient pre-op to post-op with using a 3D printed model as a guide for us. And lastly, an extremely important part of patient-specific constructs and planning is really being able to visualize a lot of the structures, including the soft tissue, the nerves, the CSF, and blood vessels in a 3D model. And so here's a patient of mine, 50-year-old female with spina bifida, prior Harrington rod surgery. She had a prior surgery for spina bifida as well, lower down. And so the anatomy here was quite abnormal. And so this is an example of what we can then do with these 3D printed models to understand the anatomy. You can see this blue is really a big patch of dura that is abnormal. And then anteriorly as well, you can see the vascular anatomy is abnormal in this patient as well. The right hemipelvis is essentially missing. So lots of information that you can gain from these patient-specific, custom-made virtual models to try to understand the anatomy better. So overall, in my streamlined workflow for performing a patient-specific plan and construct involves initially understanding the reason for the surgery, what the surgery is going to be, deciding which alignment methodology I'm going to use for that specific patient, and I use different ones based on the patient. Planning the screws, I send that screw plan to the software engineers for the rod software, so they can merge my screws and rod planning together to make the rods that I want to get. And typically I use custom rods for essentially all my cases, and depending on how big the case is, I may have 2, 3, or 4 rods manufactured. My screws are then planned with the robot, and the screws are all ready to be implanted because I've already planned the screws. And then I have 3D models ready for complex cases when needed. And so all of this, putting all of this together, even for very complex cases, can minimize the variability in surgery and can improve significantly the predictability of the outcome that you have and the alignment that you're going to get. Once again, I thank you very much for inviting me to give this talk.